Today we're talking with the Department of Health on something that's really hitting close to home. Overdoses in northern New Mexico. Taos, Rio Arriba, and Santa Fe County are all seeing spikes. And we're here today to talk about what's driving that. How can we make a change? And most importantly, what are we doing on the ground to save lives? So let's talk about it. Welcome to Beyond County Lines.
Beyond County Lines, your communities flow. Santa Fe County updates, everybody wants to know.
Before we get started, I want our listeners to please listen with an open heart and an open mind. We all have our struggles, and the best way to move forward with this is to understand the process and understand what we can do and understand what harm reduction is.
My name is David Daniels. I am the harm reduction section manager for the New Mexico Department of Health. I have been doing harm reduction for over 17 years. To be honest with you, fun fact, Phil Feudy was the one that actually certified me for the first time to conduct syringe exchange along the U.S.-Mexico border. So,
wow.
Yeah, super excited.
Did you say 17 years?
Over 17 years.
Over 17
yeah.
years. Wow,
Mm-hmm.
That's amazing. That's amazing.
Right. I'm Philip Feudy, and I've been doing this kind of stuff since the Stone Age. I got involved in harm reduction, above ground harm reduction with Albuquerque Healthcare for the Homeless in 2001, and was recruited by the Department of Health to come and be the program manager for that. And I was the second program manager from 2002 to 2006. And currently, I'm employed by a company called Vital Strategies, which is a global public health organization that is part of Bloomberg Philanthropies. And the only domestic program that they have is overdose prevention program. And then they pay my salary, but I'm embedded at the Department of Health and take my direction from Dave and many others.
Awesome. With this topic, we're going to have a series of podcasts. So we're going to talk with elected offices to talk about what they're doing. We're going to talk about people that have lived experience, and that's a story to share. I think when we get to that point in this series, it's going to be more engaging and people are going to hopefully relate a little bit more. So for those of you tuning in and listening and viewing right now, today we're talking with the Department of Health, and we're going to hit some topics that are really close to home. Overdosing in Taos, Rio Arriba, and Santa Fe counties are all experiencing a spike, especially in young adults. And today we're going to get down to what's driving that change. How are we going to address it? And most importantly, what are we doing on the ground to save lives?
So you're right. You know, we are experiencing a spike in those three counties you had mentioned, Santa Fe, Rio Arriba, and Taos. With the harm reduction program, we were blessed to get an ACP program, Alderant Checking Program, specifically for drugs that come off the street. So someone can come into our public health offices with an illicit substance, and they have a question about it, and they can run it through one of our checking machines. And pretty quickly, we can let them know if there's fentanyl or if there's xylazine or if there's medetomidine in it. And so I believe it was earlier this year, we started seeing something a little bit weird in these machines. It was a spike in fentanyl. So, Phil is actually the lead tester for the machines. He receives the reports from all of the sites that we have here in New Mexico. And so across those sites, we started to see a spike in fentanyl specifically. And I'm sure Phil can tell you a little bit better, but normally we wouldn't see anything register in regards to fentanyl on these machines. But during this time, we started seeing it register on the machines, which means it was greater than 1%.
Greater than 5.
Greater than 5%. Yeah. So, normally when someone is taking this illicit substance and it's less than 1%, they would expect to feel well, essentially. No more pain, no more withdrawals, no more issues. But when it starts to get in those higher levels, someone that's expecting to feel well when they take this illicit substance, they begin to overdose. It's a little bit more than what their body can handle. And so we started seeing that earlier in the year. I don't know, Phil, if you had anything to add on that.
Sure. not all public health offices. We have 4 pilot sites in New Mexico right now. One in Espanola with the Mountain Center, one in Albuquerque, one in Roswell, and then I'm also providing the service out of the public health office in Las Cruces. So the way that the mass spectrometers work, shoots an infrared laser through a substance and then measures the amount of light that's absorbed by the different molecules, and then creates a spectra out of it. And what has been dominant in the fentanyl market since about 2020, early 2021, has been almost primarily the counterfeit pills or the blue M30 pills. And having those lab analyzed, they tend to be less than 1% fentanyl, which is what Dave was saying. And the machine can only see things that are about 5% of the total mass or greater.
Okay.
So we can see other things that are there, but then we'll use test strips to confirm the presence, a yes-no confirmation, and then we send a sample to the lab for all the things. So what started happening early this year, like in April, is we started, all the technicians were looking into the machine, including myself, looking at the spectra, and we're seeing fentanyl like clearly, which means that there was a lot more of it than what we had been seeing for a long time.
I see. And fentanyl gets a lot of attention. Is that still the main driver, or are there other drugs showing up more often?
When it comes to opiate overdoses, at this point in time, fentanyl seems to be the main driver that we're experiencing in the state.
When you talk about with people who use, how different is what they think they're taking from what they're actually taking?
Wow, that's a hard question. So, when we're dealing with illicit substances, essentially these recipes are made off the street. So there is no regulation, there's no protocol, there's no set instructions, we'll say, that someone, when they decide to create a powder or a pill and then put it on the street, to say what it's made of. There's a lot of precursors. There's also additional substances that sometimes people may put into these batches to extend the feeling, we'll say, of fentanyl. Normally, if something is pure fentanyl, that high that someone would experience would last maybe 20, 30 minutes or so. But when they start adding additives like medetomidine or xylazine, instead of that high lasting 20, 30 minutes, it can now extend it to about 5 hours or so. So, it's just a matter of who's making the batches and what their current recipe would be.
Yeah,
so it's hard to say when it comes to illicit pills.
Yeah, I understand that. One thing, just to bring it to like a personal level, I was driving down Cerrillos Road and I stopped at a store and there was somebody, a homeless person outside. I don't know if they were homeless. They were sitting down asking for money. And they called me out. They said, "Daniel, is that you?" And I looked and I kind of recognized the person. I didn't know how to interact. I'm kind of afraid to share this now that I'm saying it out loud, but it was extremely uncomfortable because I don't carry cash, number one. I don't know if I 100% know this person or they just know who I am. But they called my name again and I said, "I'm sorry, I don't recognize you." And then she said my last name, "You're Fresquez, right? And your brother," and then she started listing off my brothers and sisters, and I was like, okay, she absolutely knows who I am. And it turned out she was a first cousin that I just did not recognize because of her use. And I don't know what she was using, but she was definitely under the influence of something. And it was just a horrible feeling seeing somebody that I'm related to not even being recognizable and going through the struggles. And from your perspective on the ground, who's being impacted the most by this?
Thank you for sharing your personal story, by the way. That's real powerful, and sometimes it's hard for us to share personal stories like that. When who's being affected by opiates, we can say it's anybody. Opiates and substance abuse or use doesn't discriminate. It's just that anyone can be affected by this. Sometimes people have certain lifestyles that allow it to be hidden. It doesn't really come out. It comes manageable. And then it's only until they ask for help is when it becomes outside and open to the public. Others, maybe those that are experiencing homelessness or are currently unhoused, they may not have a place or have a way to safely use or even to seek the type of help that others may be able to receive based on finances. And so that's kind of what we may be seeing out in the public. And so just to make that be aware, it does not discriminate. So it is not every single person that is currently unhoused. It is not someone that you may be passing on the street. It could be someone in a suit and a tie, walking past you, and you would have no idea because they have it under control or managed at that point in time. But always when it comes to these substances, when you get a little too far down the hole, we'll say, using to a point where now we're seeking in order to stay well, that should be a sign, that we could seek some help, offer some services like medications for opioid use disorder. There are medications available so that people can continue living a healthy lifestyle and have it maintained, we'll say, almost like diabetes, right? Someone may have diabetes and you take insulin or you take your medications. As long as it's managed, people don't seem to get into trouble with their health. And so opiates could be viewed the same way. Once someone recognizes and realizes they have a use disorder, there is help available.
Yeah.
Well, and I'd like thank you also for sharing that. I would like, though, to back it up a little bit. And I think since the past couple of years that I've been really focused on this and participating not only with the other folks that are doing the work here, but with colleagues nationally, and really going deeper into like the drugs on the street thing. And my takeaway at this point is that none of us really know anything about drugs, right? We've had, it's been 111 years since the Harrison Narcotics Act was passed and basically criminalizing a whole bunch of people that the day before had not been breaking the law. It created the black market and highly incentivized black market. And I don't think in these situations, so when I go out and present on this information and am talking to people, other providers and people like here at the county that are wanting to know what's going on, there is everything that people think about drugs comes through that lens of prohibition. And a lot of what we believe is not true, right? And, drugs do not cause addiction, right? Addiction is a constellation of symptoms that can be, whatever's going on with somebody. And that substance, when they encounter it, needs to address some issue that hasn't been addressed by other means. And then the focus starts on that. So fentanyl in and of itself is not dangerous or bad. Unregulated fentanyl is dangerous, right? And it's the same with all the other substances. Alcohol is a little different, but really, most people don't use themselves into an addiction, right? That comes from elsewhere. And I think I was thinking a lot about this on the drive up. And I think one of the things we always start from these conversations by saying drugs are bad. What are we going to do about the drugs? Mm-hmm. And I feel like we don't need to do, it's not our job necessarily in harm reduction to do anything about the drugs, right? Our job is to treat the people, right? We treat people, not drugs, right? And we have this clever thing that happens in this country where someone encounters a person like you just shared, and we blame them, right? That they do this and they did that and yada, yada, yada. And then until they die, and then it's somebody else's fault.
Yeah.
Right. And we go back to blaming the drugs and doing these other things. And so Santa Fe, there's a lot of disparities in our society today, but it's I just had two big events. My 61st birthday last week, and on October 1st was 40 years that I've been in New Mexico. And thinking about the differences from 40 years ago when I first came to Santa Fe, and now the disparities that are impacting people are on full display every day when you drive up and down the streets in Santa Fe. Yeah. And until we're willing as a society to look at those and start figuring out how we're going to treat that, we can't treat substance abuse in a vacuum, right? You can't take somebody off the street and put them in treatment for a while and then say, okay, bye.
Yeah.
And I'll stop there, but there's more, right. There's more points.
Yeah,
connected
I'm
to
sure
that.
we can go on for hours on this topic.
Yeah.
So you've mentioned harm reduction, and I want to just bring this topic up for the listeners so they know what harm reduction is and why it's so important. I think that's kind of where you were going with what you're saying. If one of you can just explain harm reduction, because I'll say I manage our social media pages, and when we post anything with harm reduction, everybody, I think, is just seeing it in a different lens where it's kind of what you're saying. They're seeing it as it's a drug. We need to stop this drug versus we need to help this person.
Right. Harm reduction is simply a philosophy. We meet people where they're at in their various stages, and we try to help them live a healthier life. To take harm reduction in a whole new spin, when it comes to sunscreen, right? If it's hot outside and the sun is at a certain UV, it would be considered a form of harm reduction to put the sunscreen on your skin. You're still going to go outside. You're still going to have a good time. But it's doing that activity as safely as possible. So when it comes to harm reduction in substance use, it's recognizing that someone may be at a certain level in their substance consumption, and it's not necessarily saying stop at the moment, cut everything cold turkey, right? We're willing to help the individual lead towards that healthier lifestyle. When it comes, we'll say, to smoking cigarettes. If someone smokes a pack a day, a harm reduction approach would be instead of smoking 20 cigarettes in a pack, how about try smoking 19 or 18, and see how you feel after that. And we would consider it a success if someone came to us and said, you know what, instead of me smoking a full pack, I smoked 19. We'd say, that is excellent. You know what? You're on your way towards, improving, or if you feel that you want to quit smoking. So try smoking 19 cigarettes for the whole week, and then next week, let's see if you can smoke 18. If you can't smoke 18, how about you smoke a half of one, so 18 and a half, and then you save that one. So it's taking the baby steps to eventually get to the point where someone says, you know what, I don't need this anymore. I can deal well with it. So it's a different approach, I assume, than going directly into a treatment center or cutting everything cold turkey. We're taking a realistic approach, a humanitarian approach towards substance use and meeting people where they're at, essentially, and getting them to that right stage.
Awesome. Thank you so much for explaining that.
Yep. And it's a behavior. It's also a behavior change model. And in treatment, and other behavioral stuff, there's a I don't know what you even call it, the idea of the stages of change, right? So what Dave was just describing, somebody is smoking cigarettes and they like smoking. That's pre-contemplation. Then they get an idea that maybe they want to quit. So that's contemplation. And then there's practice, right? Which he just said, maybe I'll see if I can not smoke today. And then there's the action step where you like do something and then you get your goal and you it's maintenance. And so when most people think about treatment with drugs, they're only thinking about the action and maintenance thing. And what we do in harm reduction is also a form of treatment, but we're working with people who are in the pre-contemplation, contemplation practice, and helping people to make that step. What I experienced working up in Rio Arriba for 10 years was the idea of the redemption arc, that when people think of recovery, that's what they think of, that people had something, lost it, and now they're getting it back. And as we were seeing more and more young adults, and the business was unfortunately increasing, I started to realize that none of the people that were coming to us had never had anything to lose. And so helping people navigate these systems was more than having them fill out a piece of paper and making a phone call. As people who can't read and write, they have no experience paying rent. They've never had a job. They don't know how to pay bills. They've been using free phones until the minutes are gone, and then they get another one. And so, and I'm not saying this as a judgment, I'm just saying that that's, again, kind of where we've come to. And so our focus of our work began to shift to take into consideration that if somebody is asking for help, we have to take on the whole person in order to truly help them.
I'm going to go back to my personal story real quick because I have a question on if I were to come up to you and say, I ran into my cousin, I want to help her, what guidance would you give me to then help somebody in need? That's somebody that's struggling.
Yeah, that's a tough one again too. If harm reduction philosophy is we meet people where they're at. So the tough thing that I'm going to say is someone has to be willing and recognize themselves, as Phil had mentioned. They got to be in that contemplation stage in order for us to do these things and to make it stick, make it resonate within that person. What we found is if we send people directly to treatment, it's not as successful as someone says, you know what, I need to be in treatment. I need that help. So
that makes sense.
So I would say, in having a discussion with someone, a loved one, and again, this is a tough thing to say, but are you ready to quit? Are we ready to do this? Because once that happens, then the doors are open, and that window can actually be very, very small. Someone can be ready to quit at the moment. But then, a half hour later, I changed my mind because I made my connection and now I'm doing what I do. And so we try to find that window period as best as we can. And I'm telling you this, and I'm going to put myself in your shoes. If this was my daughter, it would be a very, very hard thing for me to say, you know what, let's wait until you're ready. So I can recognize that, the human feeling, the human emotion, when it comes to getting someone well, how we want on our timeline. But again, the thing about harm reduction is when we focus on the individual, it has to essentially kind of be on their timeline when they're ready in order for make the treatment as best as possible.
There's a few weeks ago, well, about a month ago, this woman appeared in her car up at the corner near where I live, and it's a little busy intersection, and she's waving the sign, please help, da-da-da-da-da, and after seeing her for a couple days, my wife stopped and asked her, what she needed or what was happening, and she pointed at the tire of her car, and it was all messed up, and she said, I'm trying to get this fixed and stuff. And so my wife said, I will go to the tire place and pay for this, and you just have to take your car there. And she was super grateful. and stuff. And 3 weeks later, she's still there on the corner waving the sign and hasn't, gone to get the tire taken care of. And so my wife and I were talking about how, like, the most blunt thing you can do is offer to do whatever the thing is that the person is asking for. But that often times is not actually what they want or whatever, or they're incapable of completing that task. And so when the staff I was managing up north wanted to always, we had to have, as our business got more and more, we had to have more and more guidelines for how we distributed food and other things. And I had staff that were like, what difference does it make how much food we give them? We just give them what they ask for, and I was like, you know what? That's not what we're actually doing here. All of these things that we have, whether it's naloxone or food or, the other supplies that we give, those are just all tools that we use for engagement. And what we're really offering to people is connection, right? And community. And so what I would recommend is going back and saying, hey, blah, 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 and start engaging just as a friendly manner without an expectation that you're going to do something that has never been done.
Right. Awesome. Well, thank you for that information. We are about to hit 30 minutes, but I have some rapid fire fact or fiction questions for you guys, and then I'll ask a final question if you guys want to answer, and like if you want to provide information that maybe we just didn't cover today. So I'll go over these fact or fiction questions. Fact or fiction, true or false? You cannot get Narcan over the counter.
That's false.
False. All right. I don't know the answer to these questions, so I'm going to rely on your answers. You're true. If you're true or false, and I'll look at Chanel like, is that true?
Can I add something to that?
Yeah.
In fact, you can go on our website and get it sent directly to your house. It'll be mailed to your house at nmharmreduction.org. You go on that website and click in the upper right-hand corner. Just add a couple of bits of information so that we can mail it directly to your residence. So nmharmreduction.org. That is clearly over the counter at that point.
Awesome. Thank you so much. All right, next one, medication-assisted treatment. Medication-assisted treatment is just swapping one drug for another.
No, false.
False. All right, Chanel, checks out.
Do you want to say why? I think it's important to say why.
Oh yeah.
Well,
why?
Yeah. So MAT, that includes medications for opioid use disorder, along with behavioral therapy, counseling. We'll say fellowships into NA or AA. So it's not swapping one substance for another. As we had mentioned, when it comes to illicit substances, you can't possibly know what's in that recipe, what's going on with it. It could cause overdoses. When we talk about medications for opioid use disorder, included with MAT, we're talking buprenorphine, Suboxone, methadone. Those are approved by FDA. They are highly regulated. They are prescribed by a medical physician. And so there's a treatment guideline and process when it comes to that. So that kind of makes it like the diabetes insulin thing. If you're on MAT receiving buprenorphine or methadone, you are regulated in your use disorder, and so that leads you to the path towards potentially leading a normal, healthy lifestyle.
Right, and there's changes that actually occur in our brains and the chemistry of our brains and the structures, and to just abruptly stop that, most people don't think about how the words that they say or the things that they do are actually all connected to these chemical reactions in our brain. And what the medications do is allow a person to become stabilized, working with professionals, being able to get a job again, and start taking the steps to towards a normal kind of life, right? Instead of just pulling the plug and saying, okay, now you're going to do it this way, right? Which most people cannot do.
All right, awesome. One last question, and we'll go to one last true or false, and we'll go to final thoughts. The never use alone message encourages drug use.
No. So never use alone. It allows someone, if someone begins to experience an overdose, they can apply naloxone or Narcan to reverse that overdose so that they don't possibly pass away.
Awesome, thank you.
You hear a lot these days of, on the national discussion where people are like, why should we just keep giving them naloxone so they can keep overdosing, right? And but I like that the dose of reality from the healthcare authority early on in their campaign had these posters that said, Narcan enables breathing,
Hey.
right? Which
Nice.
I really liked.
Yeah, I like that too. All right. Do you guys have any final thoughts before we end the podcast?
Yeah, I do. So when it comes to substance use, there's studies on how many times it takes for someone to actually quit a substance when they first start. So using myself personally, I used to smoke cigarettes. I couldn't tell you how many times I actually tried to quit smoking cigarettes. I knew for a fact it was bad. In fact, I was going to be a health major in college, still smoking cigarettes. It felt, contradictory to me. I must have tried at least 20 times to quit smoking cigarettes until it eventually worked. I needed a pretty powerful thing happening in my life in order to quit using cigarettes. And so when it comes to any type of addiction, just understand that harm reduction helps with that. It helps with understanding that someone can have this issue and then relapse, go back, and then come back and then say, you know what, I'm ready to do this again, and as many times as it takes in order to get healthy. So that's the philosophy of harm reduction, is meeting people where they're at and helping them take the baby steps in order to get well.
Awesome. Thank you.
We're again, as a society, we're entering into a time where people have other ideas about how to go about doing things. And there's been a lot of maligning of harm reduction work, right? And this came out of the decriminalization effort in Oregon, where they enacted this and tried to pair it with harm reduction services and stuff, and it was woefully underfunded. It was that's a whole nother hour of talk. But then the opponents came out after a year and a half and said, well, we've tried harm reduction and it doesn't work, as if a year and a half was going to undo 110 years of the other thing, right? New Mexico has always been very forward thinking on this. And we have probably the most comprehensive program of its type in the country. And so not only is there the frontline harm reduction services, so that's syringe exchange and other supplies, and some of the programs do medical and food and that, but then we've brought all these other things together. So there's the Pathways program, which currently the goal is to have every public health office in the state where somebody who's thinks they need MOUD, the medications, can just walk in and be seen immediately. And I forget how many offices are going right now, but where we're at in Las Cruces has been doing that for a number of years, and that's the model that we're using for the rest of the state. So there's the nmharmreduction.org website, which has all of our resources listed, plus the adulterant checking program data and all the infographics and all those things about like how to use test strips and how to respond to overdoses. Summer Heat was a new campaign. There's the home naloxone. There's what else we get?
There's messaging on there as well, in English and in Spanish. If you forget how to actually administer naloxone, there's videos on how to do that, and again in both English and Spanish.
Awesome.
And the other programs, I mean, this is we can provide access to hepatitis C treatment to HIV care. There's
Rapid syphilis testing.
rapid syphilis testing. So there's a lot that we are have been very consciously bringing together under one roof to make whatever access point people are choosing. We can facilitate them getting to somewhere else that they want to go.
Awesome. Well, thank you both for your work and what you do. Amazing things, and I can feel the positivity just at this table. But thank you for making the trip down here for the podcast as well. So
Thanks for having us, Dan.
yeah. As these trends keep evolving, Beyond County Lines is going to stay with it, talking with county officials on prevention efforts, treatment providers on the front lines, as well as people who've lived it, who have a powerful message to share. Because understanding is the first step in changing. Follow us on all major podcast platforms, as well as listen to us on Que Suave. This is Beyond County Lines.